everyone and welcome to my channel. So we have started the neonatology chapter and we have discussed the birth asphyxia and the respiratory distress syndrome. Now in this video we are going to discuss the neonatal sepsis and jaundice neonatorum. So we are having a scenario. This is neonatal sepsis. Okay, we are having a scenario that there is a 20 days old newborn who was well before develop fever, vomiting, fits, and refusal to take food. On examination, baby is lethargic with poor sucking reflex, weak cry, and bulging of anterior fontanelle. So, what is the diagnosis, investigation, the causative organism, and the combo of antibiotics which are given? Another scenario is that there is a 5-year-old baby came to hospital with complaints of reluctant to feed, fever, and convulsions for the last 2 days. On examination, baby is weak, lethargic, and having poor suction. Temperature is 38 degrees C, heart rate 150, and respiratory rate 65 per minute. Another scenario is that their mother brought 4 days old boy with complaints of not feeding well since yesterday. Baby is full term with birth weight 2.1 kg. Mother had UTI few days before delivery, but baby was born at hospital and cried at birth. Feeding was started on the next day. Initial feeds were kava and on examination baby has poor suction, jaundice, hypothermia with cold periphery and poor capillary refill. So what is the diagnosis, the cause of organisms, the investigations? We are having the diagnosis that this is the neonatal sepsis. And some of the diagnostic points are there that baby was well before but he developed a fever and vomiting after some days. Now he is lethargic and having fits or convulsions, and he is reluctant to feed, and he is lethargic and weak and poor suction quality, and also there is a history of UTI to the mother few days back. So we are having the diagnosis of neonatal sepsis. The investigation, the cause of organism for neonatal sepsis is E. coli, Klebsiella, Pseudomonas, group B Streptococcus, and Staphylococcus proteus. The investigation options which are done for the neonatal sepsis is WBC count, that is elevated white cell count or low WBC count. Then low platelets count is suggestive, high ESR, and abnormal value for C-reactive protein due to the infection. And gastric aspirate smears more than 5 leukocytes. Chest X ratios, especially in infants with respiratory distress, and blood culture, CSF culture, urine culture is done for the causative organism, and tracheal aspirate culture and gram staining for the diagnostic accuracy, and lumbar puncture is done when meningitis is suspected. The treatment options for neonatal sepsis is general measures and specific measures. In general measures, intravenous fluids are given, electrolytes balance is maintained, nutritional support is maintained, maintenance of the temperature is done, monitor the vital signs, intake output record is measured, and good O2 support is given. For specific measures, appropriate antibiotic for 7 to 10 days are given. If no evidence of meningitis, ampicillin and gentamicin is given. If meningitis or diagnosis is possible, then ampicillin and third generation cephalosporin, that is cefotaxime, is given. So we have discussed the topic neonatal sepsis. We have discussed the scenario that the following diagnostic points are there. Then we discussed the diagnosis, the causative organisms which are E. coli, Klebsiella, Pseudomonas, group B Streptococcus and Staphylococcus. Then we have discussed the different investigation options which are the WBC counts, the chest X-ray, the blood culture, the CSF culture, the urine cultures, and the lumbar puncture. Then we have discussed the different treatment options which are the general measures and the specific measures. Now coming towards the next topic, that is jaundice neonatorum. Jaundice neonatorum. Okay, we are having a scenario that there is a patient who is home delivered full term newborn developed jaundice at the age of 18 hours. She is the first issue and there is history of one abortion in the mother. Baby indirect serum bilirubin level is 18 mg, otherwise look is normal. Another scenario is that there is a 5 days old male baby who come with the history of jaundice since 1 day of life. Baby is full term but weight is 2.2 kg. He is irritable and reluctant to feed. Has total Okay, indirect bilirubin is 25 milligram per dl, while direct is 3 milligram per dl. So, what is the diagnosis, investigations, and the treatment? Another scenario is that the parents bought 3 days old baby with complaints of jaundice that appeared on second day of the age. They have already done the SBR, which has 23 milligram per dl. Okay, here the SBR is 28 milligram per dl. Now we have some diagnostic finds from these scenarios, that this is jaundice neonatum, that the serum bilirubin level is high, that is 18 milligram per cent. The baby developed this disorder after some hours of the birth, that is 18 hours, or on the second day of the age. And the complaint of the jaundice appear. So the diagnosis is jaundice neonatum. Now we are having a definition of jaundice neonatum, that neonatal jaundice is yellow discoloration of the skin, mucous membrane, and sclera in the neonates. Jaundice become clinically apparent when serum bilirubin are greater than 5 milligram per dl. The causes of jaundice neonatum are both physiological jaundice and pathological jaundice. The definition for physiological jaundice is that this term describes benign and self-limited indirect hyperbilirubinemia that typically resolves by end of the first week of life and requires no treatment. The pathological jaundice, this term describes jaundice that is secondary to pathophysiologic causes, and it may further classified as follows: indirect hyperbilirubinemia and direct hyperbilirubinemia. The causes of physiological jaundice are increased bilirubin load on hepatocytes and delayed activity of the hepatic enzyme gluconolyl transferase. The pathological jaundice causes indirect hyperbilirubinemia and direct hyperbilirubinemia. In the indirect hyperbilirubinemia, sepsis and infection is there, ABO or RH incompatibility is there, inborn errors of the metabolism are there, Crigler-Najjar syndrome, Gilbert's disease, hereditary spherocytosis, and pyranate kinase deficiency is the causes of pathological jaundice. Then for direct hyperbilirubinemia, obstructive jaundice and choledochal cyst and biliary atresia and hepatitis A, B, and C are the causes of the pathological jaundice. Now the criteria is that jaundice appear after 24 hours of age, and peak bilirubin is less than 13 mg per dl, and the rate of bilirubin is less than 5 mg per dl, and the clinical jaundice disappear by 1 week in term and in 2 weeks in preterm infants. In pathological jaundice, the clinical jaundice appearing in first 24 hours, peak bilirubin rise is greater than 13 mg per dl, and the rate of bilirubin rise greater than 5 mg per dl. Clinical jaundice persists for more than 1 week in term and 2 weeks in preterm infants. So these are the causes, the definition, and the criteria of both the physiological jaundice and the pathological jaundice. Now coming towards the investigation options for jaundice neonatum, we are having the investigations, which is serum bilirubin levels is checked, total of that of both the total direct and indirect bilirubin. Then complete blood cell count and reticulocyte count is measured. The blood group of mother and baby, ABO and RH incompatibility is tested, and direct Coombs test in infant is tested. The secondary tests are TFTs, complete urine examination, liver function test, torch antibody titer, and glucose 6-phosphate deficiency enzyme assay, abdominal ultrasound, HIDA scan, urine excretion for reducing substances, and liver biopsy. All these investigations are done for the disease of the jaundice neonatum. Now coming towards the management options. Okay, so in management options, first of all, for the jaundice, phototherapy is done. Phototherapy is most common medical treatment for jaundice in newborn. Consists of exposing an infant's skin to special blue lights, which breaks the bilirubin down into parts that are easier to eliminate in stool and urine. The indications for phototherapy are infant's gestational maturity and bilirubin levels and hemolytic hyperbilirubinemia. The complications of phototherapy are loose stools, eczematous macular rash, and overheating leading to dehydration and bronze baby syndrome. Now the exchange transfusions are done, which is the transfusion replaces an infant's blood with donate blood, is an attempt to quickly lower bilirubin level. The indications for exchange transfusion are if bilirubin continues to rise despite of intensive phototherapy or kernictures is a concern. The complications are transfusion reactions, infections, and hypocalcemia. Then pharmacological therapy is done. That is, antibiotics are given if septicemia is present. Give adequate fluid. RH disease preventable by anti-RHD intramuscular injection and phenobarbital are given in few people with conjugation defect. The specific treatment for jaundice neonatum is that is extrahepatic obstruction, biliary atresia, portojejunostomy, then later liver transplant is done. For cholestasis, that is torch, sepsis, and metabolic endocrine, treat the underlying problem. And for bowel obstruction, receive obstruction plus phototherapy. So we have discussed the case of jaundice neonatum. We have discussed the scenario that the baby is developed this jaundice after the 18 hours of birth or 2 days of birth, and he is irritable and reluctant and lethargic, and the jaundice appears. So we have discussed the definition of jaundice, that the neonatal jaundice is yellow discoloration of the skin, mucous membrane, and sclera in neonates. Jaundice become clinically apparent when serum bilirubin are greater than 5 mg per dl. Then we discuss the causes of the jaundice neonatum, which are both the physiological jaundice and the pathological jaundice. Then we discuss the definition, the causes, and the criteria for this jaundice. Then we discuss the investigation options, which are serum bilirubin level, complete blood count, blood group of the mother and baby, and direct Coombs test. Then secondary tests are done, which are TFTs, complete urine examination, liver function test, and etc. Then we discuss the management options, which are the phototherapy, then the exchange of the transfusions, and then the pharmacological therapy, and at the end the specific therapy, that is intra for portojejunostomy and the treatment of the underlying cause, and the phototherapy plus relieve the obstruction. So here we have discussed the two topics from the neonatology, that is neonatal sepsis and jaundice neonatum. In the next video, we will discuss the hemorrhagic disease of the newborn, which is the most important, and the neonatal seizures. Thanks for watching.